All right, in this section, I'm going to cover antibiotics. I'm going to cover mechanism of action and adverse effects. And then later on, I'm going to cover individual kind of disease states and where kind of each drug plays a role and drugs of choice for each kind of individual important infection. So antibiotics, definitely you're going to be tested on the NAPLEX. There are a lot of antibiotics. We use antibiotics pretty regularly in the United States. So definitely going to see test questions come up between drug interactions, adverse effects, mechanism of action. A couple of terms that I did want to throw out here and give you an example. I have seen some of these things tested before. Bactericidal, these actually destroy or kill bacteria, active functioning bacteria, versus bacteriostatic, which basically inhibit the growth or replication. So ultimately that kind of allows the immune system to kind of catch up and destroy those bacteria that are living, but it blocks them from growing and replicating. So classic bactericidal agents are, beta-lactams, quinolones, aminoglycosides. Bacteriostatic, some examples there, the tetracyclines and sulfa drugs. So just wanted to throw out a few examples there of those bactericidal and bacteriostatic, and make sure you recognize the difference between that. So our first class that I wanted to talk about was quinolones, and there's definitely lots of clinical quirks with these agents. So first off, you'll often see these in respiratory, so a pneumonia type setting. You'll often see these used in UTIs, urinary tract infections, as well. Recently, there's been a little bit more of a shift towards trying to reserve these antibiotics as maybe more of a last line type of thing due to the adverse effect profile. So you may see kind of a push towards that, but definitely in patients with complicated infections, different things of that nature, which again, I'll talk a little bit more so as I talk about each individual infection and kind of where the drugs of choice lie. So we'll get into that more, but mechanism of action inhibits DNA gyrase and topoisomerase. So this is definitely a unique mechanism compared to other antibiotics. In hospital type setting, you definitely see PO to IV switches. It's cheaper to do oral antibiotics, and we can often do this with quinolones because they do have really good oral absorption just to do that straight switch over, as long as obviously the patient can do oral medications. Now, side effects, photosensitivity, that's one that generally counsel on. GI upset, pretty much you can think GI upset with any antibiotic. Neuropathy is kind of a rare one that maybe you will see on occasion. Exacerbating myasthenia gravis, again, that's pretty rare type situation. But definitely remember tendon issues, spontaneous rupture of the Achilles tendon or other tendons, and QTC prolongation is another one to remember. I definitely remember seeing a case of levofloxacin added on to amiodarone and another antiarrhythmic, causing QTC prolongation, which led to torsades de pointes. So definitely remember that QTC prolongation, and if you got a patient at risk for that, definitely something that should at a minimum be monitored for, and maybe we make sure we have an up-to-date EKG to make sure they're okay. Avoid use for mild infections. So this is kind of that recent warning that I was talking about. So simple UTIs, sinusitis, bronchitis, definitely avoid quinolones. Cipro, generally you will not C used for pneumonia, so that's a good quirk to remember. And again, we'll talk about that as I talk about pneumonias and UTIs and so on. So binding interactions, got to remember this. Iron, calcium, those type of products can bind this drug up and lead to reduced absorption, and that reduced absorption can potentially lead to antibiotic failure, or the patient remains sick because they didn't get adequate absorption. One other thing, you may see dose adjustments for renal failure and poor kidney function. Sulfonamides, so we got sulfamethoxazole. The most common drug you're going to see is Bactrim, or Septra, and that's sulfamethoxazole in combo with that trimethoprim. Mechanism here is it inhibits folic acid synthesis, which is obviously necessary for the life cycle of the bacteria. Drug interaction, you got to remember 2C9 and warfarin. Definitely a really, really important one. That trimethoprim side of things, do remember hyperkalemia. I can't remember if I've got trimethoprim ahead here on one of the next slides, but definitely remember trimethoprim with ACEs, ARBs, potassium supplements, maybe patients at higher risk for hyperkalemia. Side effects, so photosensitivity, so the increased risk of sunburn. Skin reactions, you got to remember with sulfa drugs. So many people have sulfa allergies. So definitely if you're getting a case and you know that Bactrim is one of the drugs of choice. Let's say you're treating a UTI and you're thinking, okay, yep, going to be Bactrim. Definitely remember to look at allergies. That's something that they try to trip you up on once in a while. So definitely look at allergies when you're given an infectious disease case or question. Crystal urea is kind of a rarer one, but that's why we encourage a full glass of water and adequate hydration in using this class of medication. Rarely, maybe association with thrombocytopenia and or hemolytic anemia. Penicillins, one of the most commonly used antibiotic classes. Spectrum of activity, gram-positive type activity there usually. Amoxicillin being the most common agent I see used, certainly. We do have more extended spectrum penicillin type antibiotics, so piperacillin, ticarcillin. Piperacillin being in combination with tazobactam, and that's Zocin. Also other combinations, Augmentin, Unicin. So these contain medications, clavulanate, sulbactam, and tazobactam. These inhibit beta-lactamases. And what are beta-lactamases? So these are basically enzymes produced by bacteria that can break down our penicillin type antibiotic. Okay? So these bacteria can definitely become significantly resistant to those penicillin antibiotics, but in adding on that beta-lactamase inhibitor, it definitely provides a little bit of additional boost and allows us to get to those bacteria a little better and doesn't allow them to be quite as resistant to our penicillin type antibiotics. Side effects, we got GI, rash, allergic reaction. I would say GI is most common. As far as oral medications, you do see Augmentin used quite a bit. Side effects there, definitely diarrhea is very common, very prominent with Augmentin. Cephalosporins, so these are beta-lactam inhibitors as well. And we've got multiple generations of cephalosporins now. First generation through fifth generation. In general, if you can kind of remember which cephs are in which generation, as we get to higher generations, we get more broad coverage. So it's kind of a vague statement, but in general, I would say that's mostly true. Side effects, again, similar to penicillins, GI, rash, are kind of the common ones there. This is always a question that comes up is, can I use Keflex in a patient that's had an allergy to penicillin? And I would say that answer is, well, it depends. There is a potential risk of cross-reactivity. That cross-reactivity in various studies has been found to be relatively low, but there is a possibility. So what you're going to want to do is kind of look into the background and see, okay, what happened? If they've got penicillin listed as an allergy and they had stomach upset, severe diarrhea, something like that, well, then yeah, you could potentially give a shot for cephalosporin. If they've got life-threatening anaphylaxis, that's a little bit more of a situation where it's like, okay, what other options exist here? Okay, so again, kind of clinically assessing that patient in the event of, this is the only drug we have is a cephalosporin, and, we don't have any history of a patient trying a cephalosporin in the past. Maybe we do testing or something like that. So, again, oftentimes the patients I've found, they have tried a cephalosporin in the past, and we can just ask them, get that patient history. Obviously, that gets a little bit tougher in a case NAPLEX question type scenario, but seeing what history they give you, and then, of course, seeing if there is other options, if there is a severe type reaction that maybe led to an anaphylaxis or something. So, again, I wouldn't anticipate you would be asked that type of gray area question, but definitely some things to kind of think about. So here's the second generation cephalosporins. I would say it's definitely important to kind of know which cephalosporin is in which class, as well as maybe some of the oral versus IV agents. Most of these are oral here, but definitely good to know the different classes. I would say definitely, if you didn't know anything, I would definitely know some of the third generation cephalosporins. So Omnicef is an oral third generation. That's one I've definitely frequently seen used in management in pediatrics and use for treatments of ear infections and different things where maybe amoxicillin wasn't available or we couldn't use that due to intolerance or something. Another third generation cephalosporin you got to know is Rocephin. And I would say I would recommend knowing ceftazidime as well. Ceftazidime has some Pseudomonas activity where it can cover that, so that's advantageous versus ceftriaxone. Ceftriaxone is commonly used in maybe a hospital type setting for pneumonia. Also, we give Rocephin injections for a lot of different infectious diseases, and I'll definitely talk about that as I talk about specific indications there. Fourth and fifth generation, so Cefepime activity against Pseudomonas, so that's nice compared to, let's say, Rocephin, third generation. And again, these third generations tend to have more activity against gram-negative bacteria. They've got a little bit broader spectrum. Ceftaroline is another one there, and we do have some MRSA activity, which is advantageous, obviously, if we're looking at a MRSA type situation. So ceftaroline is a fifth generation cephalosporin there. So again, just kind of summing up cephalosporins, generally greater activity as we go up on the generations. Third generations like Rocephin, very commonly used. Cefepime, Pseudomonas, you should not, in general, see two cephalosporins used together. So you wouldn't see, Keflex used with Cefepime. You wouldn't see Rocephin used with Cefepime, for example. Okay, so definitely important to remember that. There may be a very odd circumstance where you could see them used together, but in general, for NAPLEX purposes, definitely probably wouldn't see these utilized together. Tetracyclines, doxycycline, tetracycline, minocycline, dimeclocycline. Doxycycline is probably the one I see used most. This is one I remember for kind of wacky, unique type bugs that you don't see very often. A lot of times it seems like doxycycline is the answer of a drug that might have activity or might be effective. Tetracycline, minocycline, I would say I don't see those used too often. Doxy is much more common. Rarely tetracycline, minocycline, probably for skin type reactions, maybe acne, things like that, where we're using that as kind of a chronic suppressive type agent. Mechanism of action binds 30S and 50S subunits for protein synthesis prevention. Sun sensitivity is common. GI rash, kind of very similar to some of the other antibiotics. Binding interactions, got to remember that. So calcium iron, similar to kind of quinolones there. Pregnancy, got to remember that. These meds should be avoided. Teeth discoloration is the potential implication there. Dimeclocycline, I honestly can't say I've ever seen it used for antibiotic purposes. I have seen it used for SIADH. Very rare that I've seen it used for that, but I would say that's where you'll probably more likely see that. And like I mentioned, doxy kind of for rare, unique infections. Aminoglycosides, Gent and Tobra, and these bind the 30S subunit and ultimately inhibit protein synthesis. IV only is definitely a downside with these agents. I guess there is topical eye ointment and stuff for eye infections, but for a systemic infection, IV only typically. Nephrotoxicity, ototoxicity are two things you have to remember. And so we monitor kidney function, and as a patient's taking these medications more on a longer term, we definitely need to keep in mind for ototoxicity as well. And that can be irreversible in situations. So keep an eye on that hearing. We monitor peaks kind of for efficacy, and we've got a pretty decent sized range there. And if we've got a very severe infection, we might, choose to go more towards that 8 or the top end of the range. As we monitor troughs, we're looking out for safety and toxicity. So we want to hit that trough, generally less than 2, and that peak, maybe in that 4 to 10 range. Again, kind of depends upon the severity of the infection and what's going on with the patient as far as what that target is. But it's kind of important to remember those kinetics and those monitoring parameters. Macrolides, erythromycin, azithromycin, clarithromycin. By far, azithromycin is used much more commonly. Definitely an alternative in ear infections and things like that for patients who can't maybe tolerate a cephalosporin and or penicillin type antibiotic. This binds 50S subunit and inhibits protein synthesis. GI side effects, possibility for QTC prolongation. Maybe in rare instances you may see some issues with the liver. Definitely some drug interactions, especially with erythromycin and clarithromycin. Maybe a little bit, not quite as common with azithromycin as far as 3A4 effects go, but certainly the QTC prolongation, keep that in mind in patients at risk there. And erythromycin, clarithromycin, because of those interactions, aren't used too often. Erythromycin I have seen a couple of times, sometimes for GI motility. Azithromycin I have seen sometimes chronically in severe respiratory COPD type patients there as well. So a couple of kind of unique uses that maybe you'll see. Vanco, so this is a cell wall synthesis inhibition, binds dealanine, dealanine as part of that bacterial production process. Nephrotoxicity, so got to monitor creatinine, kidney function. GI, adverse effects, red man syndrome. Remember that there's poor oral absorption with vancomycin. I've definitely seen that question come up. Can we switch them to PO vancomycin? And the answer is absolutely no, because we don't have adequate absorption for something like a pneumonia. Now, in something like C. diff, we can use vancomycin orally because that infection is contained in the gut, and we don't need systemic absorption there. So, as far as monitoring, lab monitoring, as far as concentrations go, we usually target between 10 and 20. And again, this is depending upon lower end or higher end, might be based upon clinical judgment, how the patient's doing, how severe is that infection. So, important things to remember there with Vanco. Nitrofurantoin, so this is kind of a unique mechanism in where we form some reactive intermediates with this medication that can damage and inactivate bacterial type proteins. So side effects profile, GI, rarely you'll see some brown and orange colored urine. Rarely you may see nitrofurantoin lung. So this is a type of breathing difficulty. I would say it's probably more common in longer term higher doses, so maybe patients on UTI prophylaxis. Avoiding alcohol is recommended with this one. Also keep in mind that this tends to be focused on working on the bladder and the urinary tract. Okay? So if you've got a patient that's maybe displaying signs of sepsis and or kidney systemic involvement, this drug really only works more locally in the bladder and that urinary tract infection. Okay, so very, very important to remember that if you've got potential systemic involvement, nitrofurantoin absolutely will not do you much good. Okay, very, very important to remember that. As far as kidney function goes, if you've got somebody with really, really poor kidney function, this drug should not be used. Okay, and there is a little bit of gray area now. It used to be recommended to contraindicated less than 60 mils per minute, which isn't a very great threshold, particularly in our geriatric populations. A lot of patients are lower than that. But there is some evidence now that it might be okay in kind of mild to moderate kidney impairment. But definitely anybody with severe impairment, definitely avoid nitrofurantoin. Carbapenems, these are a broader spectrum agent, same mechanism as the penicillin antibiotics, where they inhibit kind of that cell wall synthesis. GI, rare changes in hemoglobin, white blood cell counts, LFTs. Again, pretty rare on the side effect profile there, but in rare situations can be significant. Rarely you may see seizure risk increase with these medications, maybe more so particularly in patients on valproic acid for seizures, as it can reduce those concentrations. Imipenem, meropenem, doropenem. I did note ertapenem specifically maybe has a little more narrow spectrum. It may not cover Pseudomonas as well, and or penicillin-resistant pneumococci. Okay, so definitely bigger, broader spectrum agents with these carbapenems used for more severe, life-threatening type infections, highly resistant type infections as well. Metronidazole or Flagyl. So this breaks down the DNA structure of bacteria, which obviously ultimately inhibits formation, production of necessary proteins and things like that. So really, really important education point. So a patient who's an alcoholic definitely have to reassess, is this the right medication, and or is that patient truly going to avoid alcohol while taking this medication? You can get that disulfiram reaction with metronidazole and combination with alcohol. GI side effects, potential for rare CNS side effects. May see some taste issues with this one, a metallic type taste. Neuropathy is a potential rare adverse effect there too. So metronidazole, definitely an interaction with warfarin. I would say that's an important thing to remember. Raise INRs significantly. Fosfomycin, I would say this is one that's rarely used. I don't see it used much at all. Maybe could be used a little bit more, but I think the expense kind of drives patients away, drives providers away, and the lack of poor coverage by insurance companies. So this inhibits with cell wall synthesis, specifically phosphenolpyruvate synthetase. Hopefully I said that right. Studies have shown that it is equally effective to nitrofurantoin and trimethoprim sulfamethoxazole. This drug is primarily only going to be used in urinary tract infections. And again, similar to that nitrofurantoin, if you've got any type of systemic and or kidney involvement that we're worried about in that infection, this drug should be avoided. Clindamycin binds the 50S subunit, inhibits protein synthesis there. Along with the Flagyl, it can kind of have that metallic taste. Okay, so that's kind of a unique adverse effect there. It does have a boxed warning for risk of colitis, C. diff infections, and those type of things. As far as activity, skin infections, it does have some MRSA activity, so that's a nice potential oral option with MRSA activity. Often used in gynecological infections. Again, we'll talk about those as I talk about kind of each specific disease state. Clindamycin is also available as a topical antibiotic used in the management of acne. Rifampin, you got to remember that this is a potent 3A4 inducer. As far as the mechanism, it does inhibit RNA synthesis. May see it used in meningitis prophylaxis, osteomyelitis add-on. As far as monitoring parameters, side effects, usually pretty well tolerated, but keep an eye out for those drug interactions and possibility for impacting liver function tests. Daptomycin, got to remember interaction with statins here and potentially elevating CPK and increasing the risk of rhabdomyolysis. As far as mechanism there, it can cause bacterial depolarization, which stops DNA, RNA, and protein production. Skin and soft tissue infections, endocarditis, avoid in pneumonia. Okay, really, really important to remember that. It can impact lung surfactants or can be deactivated by lung surfactants, so it is not good in the treatment of pneumonia. MRSA, VRE activity is really what's nice about this, but certainly very, very expensive type medication. Linezolid, this binds the 23S subunit, which is contained within the 50S subunit, and that leads to the blockage of protein production for the bacteria. MRSA, VRE, vancomycin resistant enterococcus, it is a potential option there. GI, myelosuppression, so suppressing white blood cell count and things like that. Neuropathy, maybe rarely. This is definitely one you got to remember as far as serotonin syndrome goes. combination with SSRIs, SNRIs, TCAs is not recommended. So what do we do in our patients that have chronic depression? They've been on an SSRI for forever. What do we do with those patients? And it is a tough call. I would say the majority can get by with holding that SSRI maybe for a week or as long as we're on the Linezolid. If you've got a patient that's got really severe depression and maybe an incredible response from one of these agents, I have seen some clinicians reduce the dose and monitor for signs and symptoms of serotonin syndrome, but generally it is recommended to avoid these agents, okay? So definitely keep an eye on that as far as a test question go. I've seen that certainly come up. And there is MAOI activity, which kind of leads to why it's so important as far as the interaction with SSRIs, SNRIs, and TCAs. But also there is potential for those food type interactions as well, leading to a hypertensive type crisis.